So, I want you to close your eyes for a second and just, try to transport yourself back to Vienna, 1847.
Okay.
You're walking through the corridors of this grand hospital. It's supposed to be a place of healing, of science.
Right, that's what the sign on the door says.
But when you walk into the maternity ward, the first clinic, you get hit with this smell. It's the smell of sickness. And you see something truly terrifying.
Healthy young women. Women who just gave birth.
Exactly.
Yeah.
And they are dying, just in droves. They're burning up with fever.
Puerperal fever, childbed fever. I mean, in some clinics back then, mortality rates were, hovering around 18, maybe 20%?
1 in 5 women. Imagine that. 1 in 5 not making it home with their baby.
It's unthinkable now.
It is. And so you, being this keen observer named Ignaz Semmelweis, you notice something disturbing.
A correlation?
A very clear one.
Yeah.
The doctors and the medical students delivering these babies, they're coming straight from the autopsy room. They're dissecting cadavers, wiping their hands on their aprons, which was, the style, and then walking right into the delivery room.
To a modern professional, or really to anyone that is it's horrific. It's the stuff of nightmares.
It is. So Semmelweis suggests this radical idea. He says, hey, maybe we should wash our hands.
Specifically in a chlorinated lime solution.
And the results are just, boom, instant. The death rate plummets from 18% down to about 2%. He's found the cure.
But here's the thing, and I think this is why we're starting with this story.
Right, the kicker. Instead of giving him a medal, his colleagues, they're furious.
They were insulted. The whole medical theory at the time was about miasma or, bad air.
Not particles on a gentleman's hands.
No. They relied on their experience, which told them they were doing nothing wrong. They mocked him. They ignored the data. Then they basically ran him out of the profession.
And that tragic story is the perfect anchor for our deep dive today. We're getting into a massive, really comprehensive text called Evidence-Based Obstetrics and Gynecology.
And that central tension is exactly what Semmelweis faced. It's the battle between experience-based medicine, doing what we've always done because it feels right,
versus evidence-based medicine, or ABM, where you follow the data even when it completely contradicts your intuition.
It's such a crucial distinction. I mean, medicine is often called an art, but this book really argues that its foundation has to be rigorous science. The editors, Noritz, Zellup, Miller, and Keefe, they've put together what is essentially a roadmap for the entire field.
Moving it out of the realm of tradition and into the realm of, proof. And our mission today is to be your guides through all this density. We're going to summarize the key educational takeaways from the philosophy of evidence all the way to the nitty-gritty of emergency deliveries.
And just a quick reminder before we really get into the weeds, we are summarizing a textbook for educational purposes. This is for students, professionals, people who are just curious.
It is not specific medical advice for any individual person. So let's go back to that tension, experience versus evidence. The book actually opens with a bit of a cell phone for the field of OBGYN. Apparently, the specialty once got a wooden spoon award.
It's true. And that is not an award you want. It was given by Archie Cochran, who's basically the grandfather of evidence-based medicine.
Okay.
He gave the wooden spoon to OBGYN because historically the field was, it was arguably the worst at using randomized controlled trials, RCTs.
So for a long time, it was the least scientific of the specialties.
You could say that. It relied so heavily on the art of delivery rather than the science of outcomes.
And the book gives this terrifying example of what happens when you rely on art over data. The story of DES.
Diethylstilbestrol. Yeah, this is the classic case study of failure. In the 40s and 50s, this synthetic estrogen was pushed as a miracle drug to prevent miscarriages.
And doctors prescribed it to millions of women.
Millions. Their experience told them it worked. I mean, they'd give it to a patient, she'd have a baby. Success. Right.
That's the problem with anecdotal evidence. You count the hits, but you totally miss the misses.
Exactly. And when researchers finally ran proper RC2s in the mid-1950s, the data showed DES didn't work at all. No benefit.
But, and this is the scary part, doctors kept prescribing it.
Until 1971.
That's a 15-year gap between the evidence screaming stop and the practice actually stopping.
And the cost was just astronomical. It wasn't just that it didn't help, it actively caused harm. It exposed millions of fetuses to this drug, which led to severe reproductive issues and even a rare type of cancer in the daughters of the women who took it.
It's the ultimate lesson in why we can't just trust experience alone.
Absolutely. But the book does give us a redemption arc. It tells the story of Mont Liggins and his sheep.
This sounds like a fable, but it's real science.
It is my favorite story in the history of obstetrics. So in the 1960s, Liggins, a researcher in New Zealand, is studying how labor starts.
Okay.
And he notices something odd about his neighbor's sheep. If the sheep were chased by dogs, if they were stressed...
They'd go into labor prematurely.
Exactly. So he makes the connection. Stress leads to cortisol, and cortisol
Leads to labor.
Right. So he wants to test this. He injects pregnant sheep with corticosteroids to induce labor. The sheep delivered early, just like he thought. But the lambs, they survived.
Which shouldn't happen with preemies, should it? Their lungs are usually too stiff.
Correct. Usually premature lungs just collapse. But Liggins figured out that the cortisol had actually accelerated the maturation of the lungs.
An accidental discovery.
A total accident. And it led to using antenatal corticosteroids for women at risk of preterm birth. It's arguably the single most important intervention in all of obstetrics. It saved countless babies from respiratory distress syndrome.
And it's so impactful that the Cochrane collaboration, the same group that handed out that wooden spoon.
They use the graph of this data as their logo. It is the symbol of evidence saving lives.
Yeah.
It's the shift from the wooden spoon era to, the modern era of care.
So speaking of quality, the book lays out this pyramid of evidence to help clinicians sort through all the information. And I think most of us, we intuitively trust experts, but the book kind of flips that upside down.
It does. It puts expert opinion at the very bottom of the pyramid. The whole, trust me, I've done this 1,000 times approach, that's considered the least reliable form of evidence.
That it's so prone to bias.
Totally. So above that, you have observational studies. Then you get to the good stuff. Randomized controlled trials, the RCTs.
And at the very top, the peak.
Systematic reviews. That's where you take all the good RCTs, you pull the data, and you analyze it all together. It flattens out the outliers.
So if one study says a drug works, but 5 say it doesn't.
The systematic review reveals the truth. It's the gold standard.
The book also suggests a formula for asking questions. It's called PICOTS. It sounds a bit like a secret code.
It's a tool, really, to stop us from asking lazy questions. So instead of just asking, is this drug any good, which is super vague, PICOTS forces you to be specific.
Okay, break it down for us.
P is for population. Who are we treating? I is intervention. What are we actually doing? C is comparator. Compared to what? A placebo. Standard care.
O for outcome, T for timing, S for setting.
Exactly. It takes a vague curiosity and transforms it into a searchable scientific query. It connects the doctor at the bedside to the data in the library.
Okay, let's apply that mindset. Let's move into the clinical section, section 2, Gynecology. The text kicks off with something incredibly common, abnormal uterine bleeding.
And this is a great example of standardization. Historically, this diagnosis was so subjective. A patient would say her periods were heavy, and the doctor just had to kind of guess what that meant.
But the book says we should use strict metrics.
Right, to define what's normal. So a normal cycle frequency is between 24 and 38 days. The bleeding itself should last between 4.5 and 8 days.
Why does putting a number on it matter so much?
Because it creates a clear threshold for investigation. If a patient is outside those numbers, we stop guessing and we start looking for a cause of pathology.
Like fibroids or polyps
or even coagulopathies, bleeding disorders. It moves the diagnosis from, it seems heavy, to, this is structurally or medically abnormal.
Okay, what about early pregnancy complications? Ectopic pregnancy, where the pregnancy is outside the uterus. That used to be a guaranteed surgery, right?
Oh, absolutely. And often you'd lose the fallopian tube. The game changer has been the combination of high-resolution transvaginal ultrasound, TVS, and serial beta-HCG measurements.
Where we can diagnose it much earlier.
Way earlier, often before the patient even has symptoms, and catching it that early opens up new treatment options.
Like medical management.
Exactly. If we catch it early and the patient is stable, the evidence strongly supports using methotrexate. It's a medication that just stops the pregnancy cells from dividing and the body reabsorbs the tissue. No scalpel needed.
Which preserves the fallopian tube and future fertility.
That's the goal.
Now, speaking of fertility and pain, the section on endometriosis had this paradox that I found really surprising.
The pain severity paradox. It is one of the most frustrating things about the disease. You'd think that if a surgeon looks inside and sees massive scarring stage 4 disease, the patient would be in agony.
And if they see just a tiny spot, she should be fine.
But the evidence shows there's almost zero correlation between what the disease looks like and how much it hurts.
That seems unbelievably difficult to manage.
It is. A patient could have debilitating pain with minimal visible disease. This is why the book emphasizes treating the patient, not the pictures. The evidence ladder starts with medical management.
Right, because it's an estrogen-dependent inflammatory condition. So NSAIDs and hormonal suppression.
Exactly. You tackle the inflammation and you cut off the estrogen fuel.
And if surgery is needed, I noticed the text is really cautious about hysterectomy.
Extremely cautious. There's this misconception that a hysterectomy cures endometriosis. But if you remove the uterus and leave the ovaries, you're leaving the engine that drives the whole disease.
On the other hand, if you take the ovaries in a young woman,
you trigger surgical menopause, which has all these long-term health risks for her heart and her bones. It has to be a very careful, personalized approach.
let's shift to infertility and PCOS, polycystic ovary syndrome. It seems like a diagnosis that gets thrown around a lot. How does the book say we should verify it?
It uses the Rotterdam criteria, so you need 2 out of 3 specific features. 1 is irregular periods, 2, signs of high androgens like hirsutism, excess hair growth, or acne.
And 3 is the classic string of pearls on an ultrasound.
Right, those multiple small follicles on the ovaries.
And for infertility in general, I was interested that the definition is actually time-based. It's based on the calendar.
It is. It's defined as failure to conceive after 12 months of trying if a woman is under 35. But, and this is a key point, if she's over 35, we cut that time in half.
To 6 months.
To 6 months, because fertility declines with age, and you don't want to waste 6 months just trying if that window is closing.
Now, what happens if you run all the tests, sperm count, tubes are open, ovulation is happening, and everything comes back normal?
That is unexplained infertility, and it affects a pretty significant percentage of couples. The book notes that in these cases, the treatment is often empiric.
Meaning, we don't know what's broken, but we try to fix it anyway?
Sort of. We move to things like IUI or IVF, not because we found a specific defect, but because we're trying to bypass whatever invisible barrier might exist.
Okay, let's move to section 3. Obstetrics. The high-stakes world of pregnancy management.
And the book argues that maybe the most important doctor's visit is the one that rarely happens.
Preconception care. The statistic in the book is pretty sad, actually. Only about 1 in 6 providers consistently offers it.
That's a huge missed opportunity.
It really is. By the time a woman comes in for her first prenatal visit, maybe at 8 or 10 weeks, the baby's organs are already formed. The window to prevent neural tube defects with folic acid or to stop harmful medications has largely closed.
So we should be screening every woman of reproductive age before she gets pregnant.
That's the push. The book also mentions intraconception care, which is a term I think is great.
I hadn't heard that one before. It's the recovery period between pregnancies. The evidence suggests this ideal window of 18 to 24 months between giving birth and the next conception.
To let the mother's body recover.
To replenish iron stores, to recover physically. Getting pregnant again too soon puts that next pregnancy at a disadvantage from the start.
Okay, we have to talk about hypertensive disorders, specifically preeclampsia. If you went to medical school more than a few years ago, you learned a very specific definition that involved protein.
And this is a critical update for any clinicians listening. We used to believe that to diagnose severe preeclampsia, a patient had to have a lot of proteinuria protein in the urine.
But that's not the case anymore.
No. The evidence shows that the amount of protein does not predict how severe the outcome will be. A woman can have tons of protein and be stable, or have almost no protein and have a seizure.
So the new guidelines say what?
They say if a patient has high blood pressure and signs of end organ dysfunction, things like low platelets, high liver enzymes, a severe headache, that is severe preeclampsia.
Even if the urine is totally clean?
Even if the urine is crystal clear, we do not wait for the protein. This change is designed to catch the patients who were previously slipping through the cracks.
That's a life-saving distinction. Wow. What about preterm labor? We talked about the steroids, but what about stopping the labor itself with tocolytics? Do they work?
They work, but not as well as we wish they did. The evidence is pretty sobering here. Tocolytics typically only prolong a pregnancy for about 48 hours.
2 days. That doesn't seem like a lot.
It's not a cure, it's a bridge. But those 48 hours are golden. They give us just enough time to do 2 crucial things. give the full course of corticosteroids for the baby's lungs, and transport the mother to a tertiary care center with an NICU.
So it doesn't stop the baby from coming early, but it makes sure the baby arrives in the best possible shape.
In the best possible place with the best possible preparation. Exactly.
The book also touches on things like thyroid disease and blood clots.
Right, and it makes an important distinction between Graves' disease and something called gestational hyperthyroidism, which is transient and often linked to hyperemesis severe morning sickness.
And blood clots, or VTE.
It just reminds us that pregnancy is a hypercoagulable state. A pregnant woman's blood is primed to clot to prevent hemorrhage at delivery, but that same mechanism increases her risk of a pulmonary embolism.
All right, we are heading into the final stretch. Section 4, labor, delivery, and emergencies. Let's start with the one that scares every obstetrician, postpartum hemorrhage, PPH.
The book breaks this down really well using the 4 T's as a memory aid for the causes: tone, trauma, tissue, and thrombin.
So tone is the uterus soft and boggy, atony. Trauma is there a laceration. Tissue, is there retained placenta? Thrombin, is there a clotting problem?
You got it. And once you identify the cause, there's a management ladder. You start with medical management uterotonics to make the uterus clamp down, and tranexamic acid, or TXA, to stabilize clots.
If that doesn't work,
You move to mechanical options like a balloon tamponade.
you're literally inflating a balloon inside the uterus to put pressure on the bleeding.
Exactly. It's pressure from the inside out. If that fails, you go to the operating room for compression sutures, like a B-linch, which basically ties the uterus down like a backpack.
And the final rung of that ladder.
Hysterectomy. It's the last resort. But if the bleeding can't be stopped any other way, you remove the uterus to save the mother's life.
Another area the book covers is operative vaginal delivery forceps and vacuums. And the text uses a really strong word here: extinction.
It's a real crisis in training. As C-section rates went up, the use of forceps just plummeted, and that creates a vicious cycle.
Residents don't see them, so they don't learn the skill.
And then they become attendings who can't teach the skill.
But why not just do a C-section if the baby gets stuck?
Because a C-section is major abdominal surgery. It has real implications for every future pregnancy. A skilled forceps delivery can resolve the problem in minutes. If we lose that skill, we lose a really critical tool.
So what's the solution?
Simulation. The book makes a great comparison to the aviation industry. Pilots don't learn how to handle engine failure by waiting for a real disaster to happen.
We use simulators.
They use simulators. The book argues we need high-fidelity simulation training to keep these manual skills alive.
Finally, let's talk about the most extreme emergency in the entire book: maternal cardiac arrest.
This is where that old lone cowboy model of the physician has to be completely abandoned. You cannot manage this alone. You need a high-reliability team. You need checklists.
And there's a specific time-critical procedure you have to do: the perimortem cesarean.
Or resuscitative hysterotomy. It's based on pure physiology. When a woman is visibly pregnant, that uterus is huge and heavy. If she goes into cardiac arrest and is lying flat on her back,
That uterus compresses the big veins.
it compresses the inferior vena cava. It completely blocks blood from returning to the heart. So even if you're doing perfect CPR.
It's not going to work. You can't pump blood out if no blood is coming in.
Exactly. So the rule is, if you don't get a pulse back within 4 minutes, you have to deliver that baby immediately via C-section right there.
And this is primarily to save the mother.
Yes. The primary goal is maternal resuscitation. Emptying the uterus relieves that pressure. It lets the CPR work. It's a terrifying procedure, operating during CPR, but the evidence says it is absolutely necessary.
Wow. We have covered so much ground, from washing hands in chlorine to performing C-sections during cardiac arrest. This book really shows the whole journey of medical knowledge.
It highlights that evidence-based isn't a destination. It's a constant process of updating. We used to use DES, now we know better. We used to demand protein for preeclampsia, now we know better. The field has to be humble enough to change.
So before we sign off, let's do a quick review exercise. Make sure this all stuck. I'm going to give you a scenario based on the book, and you tell me the evidence-based answer.
All right, ready.
Okay, listener, you try to get this too. You have a patient, she's 34 weeks pregnant. Her blood pressure is 160/110. She has a severe, persistent headache, and her blood work shows her platelets are dropping.
Okay.
You check her urine, and there is absolutely no protein. So the question is, does she have severe preeclampsia?
Based on the updated guidelines we just discussed, the answer is a definitive yes.
Correct. And why?
Because even though there's no protein, she has the severe features. She has the really high blood pressure combined with the headache and the low platelets. That's end organ dysfunction.
So that's sufficient for the diagnosis.
It's sufficient. You do not wait for the protein.
Spot on. It's a change that prioritizes the clinical reality over an old checklist.
And applying that knowledge is what saves lives.
And that brings us to the end of our deep dive into evidence-based obstetrics and gynecology. It's a great reminder that in medicine, the learning curve, it never really ends.
And as that story of the wooden spoon taught us, we have to be willing to let go of our experience when the evidence points us in a new direction.
Thanks for listening, and keep questioning what you think you know.
See you next time.